Hello, Millennium Live listeners. Welcome back to the podcast. It's great to have you here for another episode of the Millennium Live podcast. And we have a great episode with an awesome partner, a healthcare episode. You know, we've been doing so many different types of episodes, cybersecurity and marketing and benefits leadership. And it's always good to dive into a healthcare episode this week. So as we know it, hospitals face mounting pressure to reduce preventable readmissions and avoid costly care gaps, especially during the critical post-acute phase. And that's where patients transition to skilled nursing facilities. And with us, we have Hamad Husainy. He is the Chief Medical Officer over at PointClickCare, and he's going to be exploring how health systems are tackling data black holes and strengthening SNF partnerships, all while embedding AI-driven insights into daily workflows. Hamad, thank you for joining the podcast. Can't wait to have this chat with you.
Thanks for having us, Connor.
Yeah, of course. And for our guests, thanks for listening. As always, if you participated in the Millennium Alliance assemblies, that's great. This episode, we're going to be breaking down how predictive risk scoring works. Hamad's going to be talking about what success looks like under value-based care, and of course, where AI is headed next for post-acute care. I think we should start with the big picture, and it's why is the post-acute phase, especially the transition to skilled nursing facilities, such a critical point for hospitals who are looking to reduce readmissions and costs?
I think, Connor, in order to really tackle this question, we have to give a slightly historical perspective. My father is a mentor of mine, 75 years old, just retired from clinical practice as a neurologist. And I remember him sharing with me when I was in medical school that in the late 70s and early 80s, when a patient would have a stroke, they would admit them to the hospital. And about 3 weeks later, after some truly inpatient rehabilitation and occupational therapy, a patient would be subsequently discharged either home or to the nursing home at that point. And you fast forward to today and you use that example to think about more inpatient care is being provided in post-acute care settings and skilled nursing facilities than ever before. And as we continue down this path of innovation and care opportunities, there's more and more care being pushed outside the walls of the hospital. And so in order to do this safely and effectively, we have to really drill down on these transitions. And so when we come back to the question you asked me regarding this post-acute phase and this post-acute care, why is this phase so important and why are there such opportunities? It really comes back to the fact that these patients were admitted to the hospital many years ago. And today we're caring for these folks in an outpatient or inpatient setting that's not the hospital. And the opportunity here is to keep these folks out of the hospital, hence improving their morbidity and mortality from being inside the hospital. And so this comes along with costs. This comes along with improving quality of care for the patients we work with. Again, it's obviously a very complex, dynamic problem and opportunity. But to answer your question, that's how we see it and how we feel technology can solve problems inside the post-acute care phase.
That's a great way to start, and thanks for all you do in this space and continuing on from your father. So great to have you, and very timely too, because there are a lot of challenges that are coming up, and I want to talk a little bit about some of the biggest blind spots that health systems face today. And what you see, Hamad, what does that really mean in terms of patient outcomes and care teams?
Yeah, again, I'll lead with a historical sort of like commentary of where we came from, right? As an emergency medicine physician, someone who still practices, I trained in the mid 2000s at a large public university and public hospital. The training at that time was very centered around what's your responsibility. And so as an ED physician, my responsibility was from when that patient arrived to when that patient was discharged, what my disposition was, what my care was, and that direct interaction with that patient. And then subsequently after that, it was the hospitalist or the outpatient physician or what have you. And so when we think about blind spots, part of it is how we're educated, right? We're not thinking about the patient before they got there, after they leave so much. We're thinking about our role in the healthcare system. Our blind spots are really those transitions because I think historically in healthcare, especially at the physician level, those spots are really like sort of vague. Whose responsibility is that? And so I think opportunities that exist today are centered around how can we leverage technology? How can we leverage opportunities that are sort of independent of the current sort of silos that we've built today? And so I think to just sort of drill down even a little more, opportunities and how we educate around the healthcare continuum with the patient's perspective, but not only that, how we leverage different roles within the healthcare system as well as technology to cover those gaps that exist in those transitions.
Great points. Also in the name Point Click Care, it seems very straightforward and to the point, no pun intended here. But, solutions like yours are certainly helping health systems perform better under CMS initiatives and value-based care models. That's a given. So how do you do this? Where do you see the biggest impact of your solutions?
The way to look at all initiatives, and I think the way to look at all opportunities, is really through sort of a multi-layered approach, right? When it comes to CMS initiatives or health system initiatives or just quality of care initiatives, MIPS, like you could go on and on of the different initiatives that exist. But we really have to have at least a two-threaded approach, and that is a proactive and a reactive approach. We think about things we deal with in normal life every day. If we just were incredibly proactive, we wouldn't be able to transition when maybe life threw us a curveball. And vice versa. And so in our situation and what we are passionate about is how do we take patients that are transitioned to a post-acute care facility, skilled nursing facility, improve the care while they're there, mitigate any pitfalls that might require them to be returned to the hospital. But also, if they get returned to the hospital, then how do we address that? And so just a real life example would be a patient gets discharged, a case manager is able to use a portal solution we call pack management to manage that case with the care team at the post-acute care facility. When we see things that are changing, when we see vital signs changing or therapy that is maybe the patient was walking 50 feet, now they're only walking 20 feet, and today they didn't want to get out of bed, we can sort of have conversations proactively to try to result in less return to the ED and try to treat them more aggressively in the post-acute care facility. But holidays happen, weekends happen, nights happen. Patients get through that sort of proactive phase and they return to the emergency department. So when patients return to the emergency department from skilled nursing facilities, we can then subsequently provide a real-time synopsis that we call our SNF summary that is actually given to the provider through an integration with their EHR on their desktop to be able to really understand a 360 view of this patient and what they were, how they were being treated, what they were being treated for, who their care team is, who their family is, what their code status is at the skilled nursing facility. So we're not ordering redundant tests and ultimately not admitting patients that I'll call gray area patients, right? Where we don't really know that they need to be admitted, but we don't really have a picture well enough constructed that we feel comfortable sending them back home. And so as you can see, just outlined, there's a very proactive approach, but also a reactive approach.
There's a lot to unpack in there. We'll get to that in a little bit. And as I mentioned in the intro, Hamad, I would love to know and dive in a little bit around the technology in general and PointClickCare's predictive return to hospital, the AI model. It sounds fascinating. Would love to break this down of how AI-driven risk scoring works in practice and where are the areas of where it actually helps care teams intervene early.
Yeah. So, historically, we looked at objective data, right? We look at data points such as vital signs or labs or what have you. And that was good. I mean, I think to say that it was great is probably an overstatement. To say it's even good today is probably even an overstatement. We had to transition from there. And so how do we look at patients that from a more holistic view? So subjectively. So when we see things, words like a decline, or when we see a reduction, how do we take unstructured notes and then create a more structured picture. That's really what we're after here with AI. And so in order to be able to manage, tens to hundreds of patients at a time at multiple different facilities in one portal, we have to create sort of a grading system. And so we've effectively taken objective data, combined it with subjective or unstructured data, and been able to paint a picture and give these patients a score, a predictive return to hospitalization score of 0 to 100. And so what that does is it allows us to aim and guide our efforts. And when I say ours, I say the care team's efforts in the most productive ways. And so if you have patients that are impending transfer to the emergency department for urgent or emergent treatment that can be intervened in early, you have visibility into that sooner versus, dare I say, spending more time on patients that are maybe on their way home that have done very well in the post-acute care setting. And so all that to say, that's how we've built this AI model. And what we're also doing is taking that unstructured data also and sort of collating it into a summary. And so when those patients do return to the emergency department, we're actually providing a quick summary, which as a provider in the emergency department, I can tell you is often lost in translation or transportation.
And I mean, but it is fascinating, all the progress that's being made in these areas, especially with AI. And from your perspective as a CMO, and perhaps others, chief medical officers who are listening to this podcast, what does embedding predictive insights into the day-to-day workflows look like for frontline clinicians and SNF partners, especially one that you'd prefer to use and prefer to implement with ease? How do you ensure technology doesn't just create more clicks, but has real impact?
I think I'll just share a brief anecdote about myself. The longer I practice as a physician, when I first came into this as an emergency physician, the gunshot wounds and heart attacks and codes, and that was like, man, that's what I lived for, right? That's why people go into emergency medicine, or at least so they say, right? However, the more and more seasoned I get, I don't know if I'll use older, but seasoned as a physician, I get more and more excited today about finding inputs of data and finding inputs of opportunities for me to care for the patient in the best way. It's amazing the interactions that I'm able to have when it comes to mental health or patients that are incredibly difficult to manage because they don't have a primary care source, or they have a gap in their ability to understand the care plan. And so all of these different opportunities exist to be able to provide more better information at the time of care. And when that happens, I literally give myself a fist pump. I'm like, man, I'm fired up, man. I could have spent 2 hours with that patient. I could have admitted that patient to the hospital for 4 days, and we never would have gotten that data point. But I found it, and now the right care is being offered, not just some care. And so I think ultimately, when we start talking about predictive insights and we start talking about day-to-day workflows, I think what it really comes down to is, how can I provide myself, or how can technology provide me information that allows me to provide the right care for the right patient, not just care to a patient. And I think the closer and closer we get to what's right, I think the better it will be for providers' lives, the better care we'll be providing for patients. And I think ultimately the health system itself will appreciate that, because there will be less redundant and unnecessary care provided.
I love that. The right care. It's got to be included in the title somewhere of this episode. What's clear here is that SNF partnerships are key, and would love to know, as a follow-up, Hamad, how leading organizations here are strengthening their collaboration and oversight with SNFs, just to make sure that patients don't fall through the cracks, like you said, that they're not getting sub-care, they're getting the right care.
But I'm really excited about just the increase in accountability that I think we're seeing across the health system. And this isn't just one-sided, right? This is, because of CMS measures and because of quality and care initiatives, health system initiatives, statewide initiatives, what we're seeing is that health systems are really interested in what's going on in skilled nursing facilities. They're really interested on who's providing the best quality, who's providing the best initiatives to keep patients back from being admitted, who's got the shortest times for patients to be admitted into the skilled nursing facilities, because this is really driving care. If I can go have a hip replacement and I go to a skilled nursing facility and they've got a killer physical therapy team and an incredible occupational therapy, and the nurses are just incredible and everyone's working in a well-oiled machine, and I can get out of that skilled nursing facility in 6 days versus 12 days or 15 days, that really makes a big difference to my lifestyle, really makes a big difference to my recovery. And so what we're seeing is that health systems are sort of working with post-acute care facilities to hold them responsible, but also vice versa, where post-acute care facilities are saying, hey, this is important to us. Reputation is important. Quality of care is important. So if we're getting patients from X hospital or Y hospital, and certain things can be done on the front end to provide a better SNF experience. And so all that to be saying is that I think while they're different organizations, sometimes they're the same organization, but most of the time they're different organizations, we're bringing them together and we're using technology to communicate back and forth. So when patients are discharged from an acute facility to a skilled nursing facility, how are we getting that CCD? How are we getting that comprehensive unstructured data set that we can provide back to the skilled nursing facility to be able to get that care started more quickly? And when that patient returns to the hospital, how can we communicate that care? And so I mentioned earlier about when those patients return to the emergency department, being able to have a system that gives a sort of snapshot of what their care is, what their current clinical picture is at the skilled nursing facility. We also have a system when that patient returns from the ED back to the skilled nursing facility, being able to provide real-time data on what happened when they were in the emergency department. So all of our skilled nursing facilities have that ability through our PCC Connect to be able to visualize that real time rather than take guesses at what happened.
Awesome insights there. And covering another topic that I mentioned in the introduction, and that's being able to reduce preventable readmissions, and alongside optimizing the length of stay, they both sound like wins because they are, both clinically and financially. Curious about what metrics or results that hospitals realistically expect or should expect when they get this right.
Yeah, so I mean, I think the short putt, so to speak, here is how do we reduce avoidable readmissions, right? And what we're seeing is literally by just surfacing certain information. Because again, what we're not talking about here is we're not talking about ICU level admissions. ICU level admissions are coming back in the hospital. We're not talking about the obvious discharges. We're talking about those gray level admissions that get admitted to the hospital for generalized weakness or a mild lab abnormality or what have you. And you're basically stuck because you don't have historical data to be able to admit to discharge those patients. And so the real opportunity is can we reduce two things? Can we reduce the return to emergency departments from patients that are discharged to skilled nursing facility? That number is critical because if we can reduce that, the denominator of the next statistic, that's helpful. So if then we look at the patients that return to the emergency department from skilled nursing facility. So can we reduce those patients that get admitted? And so really what we're looking at here is reducing both the denominator and the numerator and showing real value through a proactive and reactive approach. So that's the short putt. I think ultimately what patients think about today is that I'm seeing a transition in the way they're thinking. Folks that maybe are generations, our parents or grandparents' age, there's this feeling of sorts that more is better. If I just had more care, it would be better care. But I think what we're realizing more and more is that that's not true, right? More care could be better, but better care is better. And while that sounds incredibly intuitive and almost overly simplistic, the reality is coordinating and collaborating care allows for better care. Better care allows for better outcomes, and better outcomes allows for happier patients and patients that live longer. So it's not just more, it's about having better care, and it's about providing real-time insights and collaborating that care across the healthcare continuum.
Couldn't have said it any better myself. Hamid, I think I want to wrap up here, and we do love to kind of wrap the podcast by looking ahead, kind of looking towards the future. Would love to know where you see technology and AI just having the biggest, perhaps untapped potential in post-acute care. And what's on the horizon? You're somebody who gets fired up about this work, and that's awesome. What excites you as a clinical leader?
I think that PointClickCare is incredibly well positioned and very uniquely positioned at that intersection of post-acute and acute healthcare. I think people think of AI and healthcare and they're like, well, there's going to be no more doctors and no more nurses, and we're just going to have a bunch of robots running around. That's not the vision that we see. The vision that we see, and I can tell you from the mouth of a clinician, is how do I get rid of that? How do I solve for the work that I do every day that is not value add? How can we allow technology to solve for that? And the reality is, I'm just one clinician at one hospital. But what about the CNA or the nurse at the skilled nursing facility or the physical therapist? What about the sniffist and the physician taking care of those patients, sometimes remotely and often not on site? What about the acute care facility, from the floor beds to the ICU and down to the ED? So as we look at AI, it's going to be solving for those parts of the healthcare sort of conversation that are not value add, and allow us to get to a conclusion for the question that we're asking or that's being asked of us at that moment. And so where do I envision? I envision a time where a patient comes in from a skilled nursing facility to see me in the emergency department, and I have the data readily available. I have all the orders that were ordered in the last 7 days. I have the results. And literally, I think at that point, even a prompt of what is maybe is being asked for at that point. And so, but not just that, I think taking it one step further, looking at a predictive risk score for return to hospital, but also proactively being able to manage patients based on their information, their clinical status, on what their risk of admission is, to be able to really proactively get ahead of it even further out than we're doing today. And so opportunities still exist to grow, to become more exact, to become great, not just good. And so I think what we're doing today is well on that track. Our organization is purely committed to leveraging AI in everything that we do to be able to drive value, drive care for patients, but also make the lives better of those that are caring for our patients and our residents. And so we're relentless.
That's awesome. Hamad Husainy, thank you so much for participating in the Millennium Live podcast. You're a wealth of knowledge. We love leaders like you who come on the show because the passion is there and the technology is exciting, and we're only scratching the surface of not only what's going on in tech, but all the great work that's being done at PointClickCare. I'm sure we could have a part 2 episode of some awesome success stories, that you've seen. But, in a time where hospitals, again, are having increased pressure to reduce these preventable readmissions and close those gray area gaps, PointClickCare, again, is probably one of the best partners of Millennium that can do this well and right, as you said, the right care. Again, Hamad, thank you so much for joining. Please come back again on the show. We'd love to have you. For our listeners, as always, thanks for listening to Millennium Live. We'll see you soon.